All right. Well, here we are again for another probably mostly unlistened to episode of Talking Jaws with Dr. Wasson and Dr. Bobek. Good afternoon, Dr. Bobek. How are you?
Oh, I'm doing good. That was inspiring introduction. I'm stoked. I had heard at least that we're talking about limited mouth opening today after sagittal osteotomy.
Yes,
Have you ever had that such a thing?
I have had such a thing. I would say it's not such a prevalent thing in my experience to where I would have suggested it as a topic.
Oh,
So I'm
really?
interested to get your input.
Okay. Yeah, I think this is a good topic then. Because I have found this to be a near uniform problem with mandibular osteotomy. Well, let's just say a BSSO. I find rehabbing mandibular mouth opening to be a variable that I don't have a great control on. Does that make sense? Like I feel like it's more hit or miss than I would let on, and I've been kind of flirting with a few different ideas to improve it. I kind of wanted to hear your take because I'm open
Well,
to
I
the
guess
idea.
walk
My
me through it.
experience is weird.
Yeah, walk me through it a little bit. I guess some of us wouldn't necessarily track it, measure it. In my experience, the way I deal with it is almost essentially if they're coming back for follow-ups that are normally scheduled and I perceive limited opening, then and only then do I stop and measure or address it, or the patient themselves brings it to my attention. Um, and I would say that of any TMJ symptom, if we want to throw this all into the realm of quote unquote TMJ, TMD,
Is it?
yeah, I just that's the thing is that's kind of the question I'm getting at is I almost treat it when it's been brought to my attention as a new onset quote unquote TMJ, TMD condition. So I would approach that in those scenarios as is this muscular in nature versus is this joint in nature? And then the way I would pursue it from there is dependent on that and of course the patient's wishes. But I would say that is not something I frequently deal with, but I would also say it's not something I go searching for. Are you intentional with your measuring, tracking with
Oh,
that in your
no,
osteotomy
no, no.
patients?
I'm not like pointing out to the patient that their mouth opening is limited. It's just generally people notice those sort of things. My postoperative instructions give guidance on how people should open. And honestly, a lot of those are from Myron Tucker, so they're a bit old in terms of uh, the instructions have been around for a number of years. And it just goes by finger width, like what you would expect as you recover. Maybe that causes people to be alarmed by it, but I definitely hear about it more often because I'm
I
suspicious
think
there's
you hit it.
some patient chatter online about this. Um, because TMJ is a bit of a black box, and I think it's largely for mandible surgery. So for BSSOs, um, recovery is a little bit different in a class two versus class three situation versus counterclockwise versus clockwise. Um, but generally speaking, I've chalked it up to, like what we all do. You just had surgery, so your muscles could be a bit of spasm. There's a tendon next to where we're working. You could have some tendonitis. There's swelling. We put you in rubber bands. Your mouth is open for a period of time. Like all these other symptoms. But I think what patients are worried about is they either have ongoing condylar resorption or they now have an internal derangement in their joint. I think that's what people are concerned about.
So let me back you up and then just clarify this. You're giving them expectations of opening with finger width, basically number of fingers they can fit in their mouth at certain time intervals. And so the
Yeah.
patients are usually bringing it to your attention during follow-up. Is that what you're saying?
Yep.
Okay. And then are you still seeing consistent diminished mouth opening? I'm assuming you see them at 6 weeks like somewhere around there is typically your final
Yeah, so I guess
post-op
talking about
visit?
that's good. I mean, at our practice we see people at 1 week, 3 weeks, and 6 weeks pretty reliably, and it's not perfect on the specific day. So, a 3 week visit isn't 21 days after surgery, but it's in
Right.
the third week after surgery, right? And when it comes to 6 weeks, um, it's pretty common to have a limited mouth opening. And it's at that visit that we give people formal jaw stretchers, like give them a little um like a clothing pin with some tongue blades glued to it. I've shown you this. People like either glue like tongue blades together or a clothing pin with tongue blades. So we give them those to stretch their jaw a couple times a day. And we generally have them do that for a week or two, no rubber bands for a week or two. And that seems to resolve the mouth opening. If it doesn't, it's physical therapy. Physical therapy doesn't fix it by 2 months. Then I usually like seeing where they're at because it's either muscle spasm, tendonitis, or I'm suspicious for an internal derangement. But explaining all this at like the 3 week visit, because it seems like an area of concern for people, which it may just be my patient population and not yours.
It may be that, and I do think from my perspective, I think you may be correct in the fact that by creating expectations, you're creating concern and you're creating some things because I do think, when you kind of turn them over at that 6 week mark, like most of us do, to more aggressive chewing, biting, movement, exercise, whatever it is, I think I think they improve there. I think there's an interval there that they improve. And so I would say I'm a little less, I guess, aggressive in recommending an intervention that it seems that you are. Because at 6 weeks, I kind of say, hey, once you start moving, biting, chewing, this will loosen up more. Once, my
Sure.
common refrain is the more normal you are, the more normal you'll become.
Yeah.
And so that part is apparent to me. And then I typically will, if at 6 weeks they are seemingly limited or they're concerned, then I would put them on a similar protocol. We just kind of have a finger protocol, massage and stretch. We do 10 seconds on, 10 seconds off, um, 5 times, 5 times a day is the protocol we do.
Sure.
So
Just get them
massage
on
10
some
seconds,
physical
stretch 10
therapy
seconds. Yeah,
at six
exactly.
weeks.
And then I kind of turn it over to the patient. I guess I kind of say, hey, if this is still an issue, if you're not seeing, I typically will say, hey, if you plateau, come back. If you're making progress at all, then keep doing it until you feel like you've plateaued. And if you're happy with where you are at that plateau, I don't know that we need to intervene anymore. And then if you're not, then I want to hear about it, come back. And that's when I would have a more formal physical therapy attempt, or again, make sure my diagnosis is correct, reevaluate for an internal derangement, as you said, and kind of go from there. But I mean, I would say whenever they mention limited opening, and I can visually confirm, I do at all times try to figure out the origin. Hey, is this muscle? Is this internal derangement? Are you deviating to the
You're
side? Is
speaking
this
in
a
the
hard
after six
stop?
week patient.
Yeah, I mean, even if they brought it up before, I don't know that I would commit to anything at 3 weeks or 1 week or 4 weeks as much. But if they were showing signs or symptoms of an internal derangement, it would definitely be on my radar. I mean, I would even, and
Would you
this is
do
maybe a
something different
question for
then?
you. I would consider if I truly thought I had an internal derangement, I would probably speak to the patient differently. I don't know that I would intervene, but I would consider, arthrocentesis would be on my radar. When I would implement that, I would probably still give it more time.
This is a tough
What
topic
about
because it
you?
definitely covers TMD and orthognathics, right? Because I would bet a group of people don't manage TMD or they just manage TMD and not orthognathics, right? I think both of our practices we're comfortable managing both. And we're both on board with joint stability going into surgery is typically how the joint is after surgery. That's right,
Yeah,
right? So,
that's how
if
I
it
tend to
if it
explain it
doesn't
to
hurt
patients.
much or it clicks a little bit, it'll not hurt much and it'll click a little bit after surgery. But that can change, right? Like
Oh,
what you're speaking
absolutely.
to is someone feels like their joints suck like right after surgery.
Hmm.
Have you had success with arthrocentesis post-op?
I would honestly say I've probably done it less than 5 times,
Yeah.
ever at any time point for a sagittal patient, for a
Oh, you
sagittal
mean in their
osteotomy
entire
patient.
recovery time or
Yeah, absolutely.
yeah, because it is
Yeah.
pretty unusual to need any intervention for the joint. I think generally speaking, internal derangement is an unusual outcome with a sagittal osteotomy. Um, and specifically in a symptomatic internal derangement, you need to treat. I've had a few patients go through surgery. I think I'm more in the interest of ways to improve their mouth opening more than 2 months. Because I mean, I don't think it's an uncommon thing to take 2 months to recover for mouth opening after a
Or
sagittal osteotomy.
or more. Yeah, easily.
But outside of putting temporary braces on, things like Invisalign, they may not be able to wear their trays that time. I think it's easy for people to get concerned during that time about it. So, what do you think about ways to reduce that timeline instead of accepting what we've been doing forever? Do you have a great feel on what we could do to improve it, to speed them up?
I think in the way of prevention, I think maybe less temporalis stripping might have a some benefit
Yeah,
there.
I don't
Could I
know. I
prove
mean,
it?
I've definitely been flirting with temporalis for a while. I feel like temporalis is probably the thing that's slowing us down. But I mean, at the same time, you got to strip it somewhat, right? You got to get above the nerve. I guess you don't have to get above the nerve, but I guess what we're talking about is dissection of the ascending ramus. The temporalis is it. Have we talked about my suspicion of the temporalis with limited mouth opening after injections? Have we talked about that?
I I don't think we've talked about it.
Like
You
classically in
mean,
dental school, you learn about the patient who had two, three, four, five mandibular blocks on his side because they're getting a crown or extraction, and they just don't get numb, so they keep getting extra shots, and then they can't open their mouth the next day.
yeah.
Um, you've seen those guys, right?
Oh, absolutely.
You try to get them better with heat, jaw rests, stretching, maybe physical therapy. Um,
I give them time, but yeah, time and stretches mostly NSAIDs.
and the idea
That's
is
really
they
it.
have a hematoma at the medial pterygoid.
I think that's the classic thinking is it's more hematoma um, than
Because I've
temporalis
thought about
injury.
this patient in relation to the sagittal osteotomy patient.
Okay.
Because if you do get hematomas in the medial pterygoid, let's just assume that happens from repeat injections, right? So you're just causing some vascular injury that causes bleeding into pharyngeal space that is causing trismus, then wouldn't we see that at a near 100% rate with the sagittal osteotomy? Don't you think? Or do you think the dissection plane would keep us out of that?
I would either say that I think the dissection plane could keep us out of it, and it also could open avenues for lack of hematoma formation because the bleeding could expand easier, right? Because we're disrupting the plane a lot of times.
Sure.
And you're even stripping the medial pterygoid from the distal segment. I mean, so it has different places to go
Yeah.
instead of accumulating maybe subperiosteally or in that medial pterygoid or pharyngeal space.
Because
We essentially are evacuating it.
the people that I see that come for limited opening after repeat injections are like weeks later, right? Like 3, 4,
Yeah,
6, 8 weeks later, and they just seem stuck. Like it's just like I might have got a little better, but it didn't really improve much. Um, and I think I do see those people with sagittal osteotomy, like they just don't progress. And I blame the temporalis tendon. I think what's happening is the temporalis tendon is the problem. I think tendonitis, because cornoid release fixes those patients.
that's what I was going to ask. So then, is your algorithm if physical therapy fails, you're then proceeding to coronoidectomies?
I mean, I'm certainly flirting with it. I've been using steroid injection with increasing frequency in the temporalis tendon. I think tendonitis might be a path. I just didn't know what you thought of that. It's very much an area where I'm suspicious that's what's causing his trouble. I think that's much more than internal derangement business. And I mean, there's muscle and swelling, but that doesn't tend to be that bad. Um, the other one I
What
tend to
kind
blame are
of
rubber bands. But man, with just a Lafort, people's mouth opening isn't limited at all, right? Like, I mean, it might be somewhat limited, but barely. Like Lafort patients don't seem to be concerned about mouth opening. Um, I don't know. I'm just trying to think what other ways we could do to rehab people better so that at 6 weeks, we really don't have to send them off for stretching exercises and we could send them to see their orthodontist at a month, and have reasonable mouth opening.
I mean, I think if you use a piezo and custom hardware, that will solve all of these problems. Maybe that's too inside of a joke for
Yeah,
the 12
probably.
people that might end up hearing this podcast. But
Yeah, because I mean,
um,
it's already you already do as minimally invasive surgery as you can, small incisions, minimal dissection, efficiency with surgery, all those things being true, give their mouth a break, their mouth's not open for a very long time in the osteotomy. Um, I I don't know. I was wondering what you thought of temporalis management because I think otherwise, like medication management would be the only other route or getting people in early rehab because that would
yeah,
be.
what
Where'd you
what are you
learn your
seeing with
rehab?
your I the rehab protocol I use I learned from my time at JPS during my internship
Yeah,
that
they do a good bit of surgery.
we tried to basically as a way of like one last resort to before I guess because it was a lot of those patients were coming to a county hospital, it was used as an avenue both to make sure that we've explored reasonable options prior to intervening surgically, and kind of maybe one last screening tool. Hey, if you're not compliant with the rehab, then we can't be certain you need surgery. But it was very effective in patients who were compliant and had muscular TMDs. I mean, it's nothing special. It's NSAID, soft diet, muscle relaxants if needed, physical therapy.
Yeah,
I mean, it was bare bones, bread and butter, muscular TMD that I think honestly maybe we're getting too far away from. And you see some of the patients that have non-surgical management of TMDs, and it's like, well, have you tried physical therapy and NSAIDs and soft diet? And some of them are like, no, but I've gotten all sorts of things injected into my muscles and joints, and it's like, well, why are we getting away from the tried and true non-surgical management of TMD? And
yeah.
maybe that's a whole other topic
Well,
here.
because I
Like
think
you can
largely
you
that's
can
what
do
we're
those
doing
things, but
in recovering people, right? Like our current recovery
yeah.
protocol for recovering sagittal osteotomy is non-surgical, which I think that's the right thing to do. I don't think there's anything wrong with that. I wanted to kind of talk with you out loud to talk over ways
Well,
to
let me.
improve outcome.
What do you, in the way of outcomes from your temporalis injections with steroids? What are you seeing?
I don't know if it's really improving much. I'll be honest with you, I am really flirting with the idea of talking to people about releasing their temporalis, like preemptively, like particularly in condylar resorption patients. Because I know we were just talking about that before we started recording this thing on TJR patients and whether or not to release the temporalis, um, or at least managing residual limited mouth opening after TJR. Um, I
So you're
have
saying in sagittal osteotomy resorption patients preemptively doing
well,
coronoidectomies?
so um, I think there's likely a role for releasing the temporalis in sagittal osteotomy. I just don't know where it is. I haven't started this yet. But I have been flirting with this idea for years. I just don't know if it's the right thing. I've looked in
Well,
the
let's
literature for this for some guidance and haven't been too helpful.
let me help you narrow it down here a little bit to make sure I understand what you're saying, and maybe the seven listeners also know. Are
Six.
you saying are you saying coronoidectomy, or are
Yeah.
you just advocating for stripping the
Coronoidectomy.
muscle, which seems like that may even be counterproductive?
Coronoidectomy is
Coronoidectomy. Okay.
counterproductive.
No, no, no. I was saying if you just tried to strip the muscle, you might make things worse, in theory, because you're probably not going to be able to strip it all like, from an intraoral incision. I mean, I guess you could.
The way I perceive this is to do it at the end of the split. So after you get it fixated to release it. And obviously the patient decision, like choosing the patient is going to be hard, right? Because I mean, not everyone's that worked up about limited mouth opening. A lot of times class threes, like in my world, for whatever reason, I have this perception that high angle class threes with like a steep articular eminence has a slower recovery in mouth opening. Um, Maybe that's too like specific. But generally class threes aren't going to run into too much trouble with mouth opening. Um, Whereas let's say a clinically stable class two patient we're going to do MMA on with significant counterclockwise rotation. Is there a role for releasing the tendon in their recovery?
I mean, that's a good question. Part of me wants to ask, are you solving a problem that is only minimally present?
Sure.
Like, I mean, you're probably going to be over treating. If you did that for every case, you're going to be over treating
I agree.
more than likely, if not
Agree.
certainly. But I guess, there's not a huge increase. At that stage, I would argue there's probably not a huge increase in morbidity. I would also argue that I don't know that the patients would ever know like the difference if you were to not tell them.
Yeah, and I
Most
don't want
people
to,
only
I'm
go.
not saying like do procedures on patients without them knowing. Not at
No,
all.
no, no.
I'm
But
just saying that
I mean,
like,
the morbidity would be such that I don't think that they would notice.
no, it doesn't seem like people miss that at all.
No,
Um, I'm just kind of talking out loud in terms of rehabbing people after sagittal osteotomy because most people tend to follow the typical path, and if they don't, then you can send them down the road of PT or the road of even MRI. But your clinic's like
yeah,
mine in that we don't routinely get MRIs pre-op unless there's symptoms, right? So the
no. And I
post-op
think
MRI is always hard to have a
I
lot of
get far
utility for it.
less. Yeah, I get far less MRIs. I think than you. We've had that discussion, and maybe
Yep.
that's a podcast for another day. But yeah, no. I mean, I would. I mean, getting a baseline MRI on people. Well, I mean, what do you? Why?
Yeah, exactly. Yeah, no, I think we're on board. I'm just saying the MRI post-op is always hard to interpret because it's unclear where they started pre-op, right?
Oh, absolutely.
But I would just put the plug out there that I think recovery after sagittal osteotomy is more frequently in the temporalis than it is in the joint. What do you think about that? True?
Then the
False?
joint. I
Internal
I'm not sure I'm
derangement
willing.
slowing down your mouth opening more so than the temporalis is?
I would say 100% it's muscle more often than joint. Like, and it's not close. Whether I'm comfortable attributing it to the temporalis solely, that I'm less comfortable making that leap
Yeah.
versus is it pterygomasteric and temporalis or only pterygomastoteric and not temporalis. So I'm less comfortable making that leap than I am. But yeah, 100% true joint problem creation after sagittal osteotomy is very, very minimal in my experience, unless it was pre-existing, at which point I would have probably addressed it either pre-op, that we let's get that under control before we do your osteotomies or simultaneously.
Yeah.
Is
Yeah,
that
I think
how
so.
you would? I
I
mean, I
mean,
think that's what you kind of
yeah,
intimated
no, I think
earlier.
so. I mean, I don't know. And it could be me just being like rose-colored glasses. I do feel like less stripping of the temporalis, a little bit steroid injection from time to time in the temporalis, rehabbing people a little bit earlier. It seems like mouth openings better than what they were 5 years ago. But like as a clinician, can you really compare those two things, right? Like I have Andrea. I ask her questions because she's my PA, physician assistant. So I've been working with her for 7 years. So I basically depend on her memory being more fresh on these things. Because to me, something that happened 10 years ago versus 1 year is the same timeline. It's kind of in the same memory bank. So um, I don't know. I think mouth opening after sagittal osteotomy is an area that could be improved, though. I feel like to like rehab people faster. I would also be open to the idea of enhanced recovery, the ERAS protocols for mouth opening. I'd be interested in that.
What do you
Um,
mean?
like just ways to early rehab people to get them up to speed faster. Because I
Well,
mean,
how
in
do
my
you?
world, I wait until 3 weeks, maybe 6 weeks before I'm rehabbing their mouth opening. I'm mainly concerned about bone healing and pain control and stuff like that.
I mean, I worry, to me, it's almost two different animals if they have a LaFord or not. With TJR or just a Sag, I'm much more comfortable with them putting force on the mandible than I am on the maxilla.
Yeah.
Probably because I use at least two screws and a plate, which hopefully you're coming around to this
No,
phenomenon now instead of your single screw.
no, my screws
Um,
go into both bones though. They go in the proximal and distal side. That's why I only need one.
uh, yeah, well, the nerve, like it interrupts my pathway.
Yeah, totally.
Uh, so I mean, I mean, maybe I'm wrong in this, but I always feel like my mandibular fixation is fairly solid. Now, of course, I've had some complications. I've had some cases where that is not the case, but I worry mostly about the maxilla. Like that's
Sure.
what I feel like is the rate
You're talking
limiting
about
step
early
because
rehab after a TCO.
absolutely,
Yeah.
because they essentially have to put force on both jocks
Yeah, for
to
sure.
do the rehab. I mean, they can move around as much as they want, and that's great, and I encourage that. But I'm not real comfortable till week 5 or 6 with them putting much force on a maxilla. If they were BSSO only, yeah, I think I'd actually be fairly comfortable with them putting some force on it 3 weeks, 4 weeks. I don't know. What are your thoughts on that?
Yeah, and I mean a lot of the initial stretching is more just passive stretching, right? It isn't actively pushing on the jaw, like pushing on it side to side or like cranking the teeth open. I don't like that until the other bone's healed or at least semi-healed. So I agree with you if that's what you're talking about. I mean, because we don't even really bring up jaw stretching exercises until the 3 week visit. There's a little bit of instructions. I just wonder because that's the other thing that I consider is are we too slow to get people stretching?
Man, I honestly, I'd have to go back and revisit my instructions, but I don't know that we mention jaw mobility protocols unless or until they have a problem. Like
Yeah. Okay.
I feel like they're not ingrained in our post-op instructions. I think that's a separate sheet of paper and that's a separate discussion if they develop because I feel like it's not
Yeah,
all
I might
that
play
frequent.
with changing the timing because it may be just a timing thing too. Because a lot of times the first week you're so focused on all the rest of the stuff that adding more to it can be too confusing. And there's definitely a consideration on overwhelming people. And
I think you're also just, I mean, this is opinion here, of course. I think setting expectations is a is a potential problem. I do.
oh,
I
just
feel
bringing
like,
up the amount of mouth opening. Yeah, that could be it too.
yeah,
I
I
mean,
really do. Because I mean, think about how many times we have patients who come back to us who've said, "Oh, I had a friend or a family member who had this, or I was reading online, or I'm in this Facebook group,
yeah, I mean that's most people.
and it's, anything that diverges from that pathway, they bring up as a concern, which is not inherently a negative. Like I would rather them over share with me their concerns than undershare, because then we don't miss something. But I think when you create that expectation of, hey, I'm not hitting a milestone or I'm not where I should be, that creates undue anxiety and stress for both parties now because now it's on your radar now
Well,
too.
yeah, I mean, because I think part of it's also the online community in terms of the patient's engagement for what should and shouldn't be happening after surgery. You don't really know what's being said there, right? And I do feel like that's probably a source where people can get concerned about this um, more frequently than my instructions do. I just, I don't know. There's always been something weird about a mandible osteotomy. Why it's always like we've just kind of accepted that mouth opening is going to be a bit limited for a while. Um,
I mean, you don't, I mean, what are you doing to the medial pterygoid? Are you stripping that every case?
I mean, I do, yeah.
I mean, you don't think I mean,
I
to me,
actually
that's
don't
kind
think
of
we're
a
entirely
very,
stripping the medial pterygoid. Do you
no,
think we're always
but
stripping it?
I think we're creating some separation and some space, maybe stretching more than we're stripping. But
Yeah, I mean, I think we're releasing the soft tissues from the proximal aspect of the distal segment. It's just whether or not there's much, because like where the split propagates vertically would impact how much medial pterygoid is actually attached to it. There's ones that just kind of like go vertical and shoot up, and then other ones that go along the inferior border all the way to the angle. Um, so I mean, I've always been like, I don't know how much medial pterygoid I'm stripping, but I reference it as that step. Um, but wouldn't stripping be a
But you
helpful thing,
don't,
you think?
I don't know that creating trauma to the muscle would be helpful as
Kind of
far as
interesting.
mouth opening goes.
Because don't you just do it? Do you do it in every sagittal osteotomy or just for advancements or counterclockwise rotation advancements?
Yeah, that's essentially what I was trying to ask you. And I would say for small movements, I tend to not mess with it much.
Yeah.
Um, I'm throwing out a number here. I'm going to say 5 millimeters, but I don't know that I have an exact protocol. But if I'm not doing much movement, I tend to try to leave it alone. And then if I feel like I'm not mobilized where I want to be, it's
Yeah.
the first thing I go back and do. Uh,
Yeah. Because I mean, I would say almost always I use it. I mean, I can, I don't feel comfortable ever saying 100%, but I mean, it's much more than 95%. Like every case, it's just part of the routine of performing it. It's a good thought that maybe that's contributing to problems. Doesn't seem overly invasive, but um,
what are you using? Because
just
like
a
I'm
J
using a
stripper.
saw to strip it. Like, I'm like cutting it and then releasing it. Is that not what you do?
J stripper on the distal aspect of the cut, bringing it back to the proximal aspect of the cut. Like
Wait, hold on. You're stripping anterior, posterior, or posterior, anterior. Not that I think it makes a big difference, but what do you do?
anterior, and then I'm bringing it
Back,
posteriorly.
posteriorly.
Yeah.
Yeah. And then you're then putting it on the distal aspect to see how much mobility you have. Do that
No, I don't do that.
maneuver. You just kind of do it once or twice and then you call it
Just do
good.
it to where it feels like it's loose and it's wiggly. That's good. I don't
Hmm.
know. I think that's very much one that I just hold over from my fellowship years. I haven't really altered that step much in practice, so that's a Charlotte one. I
Yeah,
don't
I
know.
mean, we were trained to do it. I think, where I trained, efficiency was probably at the forefront of everyone's mind.
Yeah,
And that was a step on everyone, which I mean, again, I could get behind. Like, if you have to go back and do it, that's not fun. That's a waste of time. Is it a huge waste of time? No. And if you saved a patient a little morbidity, I don't know that you have, but maybe. But yeah, the way I was trained, it was every case.
yeah. I'm on board with you. I think that's
But
right. I just wonder if
you,
it's an interesting thought that playing with that would influence it as well. So I don't know. I'm kind of interested in
well,
improving it. So I don't know if anyone has ideas.
let me just clarify with you. You feel like that step is not contributing much
I don't
to
think
the
so.
limited
Oh,
mouth opening.
yeah, I don't think so. I don't think,
Because that's what I've attributed a lot of it to.
huh? Yeah. That's
I
why I
don't
like
know.
talking to you about stuff, Wasson. I think looking at it at a different
I don't
angle is
know.
good because you probably didn't think I was going to talk about temporalis, cornoid release. I didn't know you were
I
going to talk about
didn't.
medial pterygoid.
No, I thought all those things. I did not anticipate the steroid injection into temporalis.
I like
Have you
that.
done Have you done Botox?
No, I mean, I have, but not in this subgroup of people. No, just because I don't think it's muscle. I really think it's tendonitis, just like the dental injection patient I was talking about. I think it's temporalis tendonitis slowing him down.
So you don't think it's myositis ossificans?
You're talking about the average SAG patient? No.
Either one, either or. I just wanted
I
to
mean,
throw out a word
of the
so people think I'm
possible things that
smart.
could be going on, certainly there's a ton of other possibilities. But I'm just speaking, the 80-90% of patients who go through mandible osteotomy, what ways can we improve their mouth opening quicker than just accepting the 2 month post-op limited mouth opening business?
So
And
where do we go
so
from here then? What's the next step to solving this problem or figuring out the cause?
I think um I think in my world, I think I could probably track it a little bit more specifically. And I want to noodle the medial pterygoid attachment issue a little bit more. So in terms of that influencing it, because it seems like it would. I mean, it seems like you're right. I just wonder how to apply it, you know?
I mean, I've also kind of attributed it to you. You are changing the anatomy around there, right? You're changing the anatomy, the healing process.
Not that much. I mean, you think we're changing that much?
Well, I mean, you're changing the shape of the mandible in that area to an extent. I mean, the vector of the muscle in theory
Yeah,
would
because I mean we're,
change.
you think?
I mean, slightly. I mean, it can't, I mean, you can't move something that's attached to something and it not change
Well, because there
at
shouldn't be too many
all.
muscles other than airway muscles that are attached to the distal segment.
I mean, if it's slinging around to the inferior border there, you don't think so?
I don't know. I mean, yeah, because
We've
I was going
completely
with
kind
you
of
already
gotten off
stripped the
topic here.
temporalis off the ramus, so there's no temporalis attachments on the distal segment. You know, the masseter, you're cutting anterior to the masseter attachment. If you strip off the medial pterygoid, lateral pterygoids on the condyle. I know some of your
Right.
sagittal osteotomies, the condyle still in the distal segment. Um, but that's not typical. So I mean, I don't know. I think part of it's the trauma of the operation and whatnot, but I think there's some area there to improve. So um, I think I'm probably getting more out of this talk than anyone listening to us talk about it. Um, but I will flirt with the idea of the medial pterygoid, maybe follow it a little closer. We've been kind of needing a new clinical project as of late anyway, so that'll be a good one.
Yeah, I mean, I guess I would just say now that you have brought it up and we've talked about it, it'll probably be on my radar a little bit more. But at the same time, I guess in my experience, I don't perceive it as a issue frequently enough. I view it more as the aberration or the outlier than a consistent problem. But as I do more and my career continues, that may very well change.
Yeah, I don't know. I guess I generally just perceive the mouth opening to be like the rest of our recovery stuff, and that um what we kind of accept to be normal doesn't necessarily have to be that, right? Like patients spending a night in the hospital or having a lot of facial swelling or bruising or being numb for a long period of time. While their final outcome is certainly very, very good, making recovery better is, I think,
Well, let me throw
an
this
area
variable
where you
out there for you.
work
I
on.
mean, third molar extractions for impacted third molars, they have
Yeah,
limited mouth opening for weeks. You know,
temporalis, temporalis.
but how is the temporalis affected from that? You're not stripping the temporalis, not dissecting the temporalis with a wisdom tooth. At least, well, I mean, I'm not. I mean, what you do up there is your business.
I'm
But
not either. I'm not either. I'm doing wisdom teeth just like anyone else. One injection, maybe a second injection for uh Marcaine or something like that. I don't really think people's mouth openings that limited with wisdom teeth. You think they are?
yeah, I mean, not permanently,
Yeah,
of
but I mean in
course.
recovery, that's an interesting subgroup of people. I feel like there pretty normal by
When are
a
you seeing
week.
your third molars back? Are you seeing? Do you see post stops routinely for third molars?
I'm gonna be honest and say no.
Yeah.
I see people
See,
back
I
when they
didn't
have
either
dry
in
socket.
Seattle.
What's that?
Yeah, so my protocol when I practiced in my Seattle practice is I only saw third molar patients back on an as needed basis.
Yeah.
So if they were doing fine going about their lives, didn't see them again. And you would frequently joke with them, haha, hope I never see you again, ha ha ha,
Am I
kind of
wrong
thing.
in perceiving that their mouth openings typically fine at a week?
So that's what I was getting at. So when I came down here to Arizona as an associate, the protocol was every patient scheduled a 1 week follow up. And so I saw a lot more of them. And I would say many of them still had limited mouth opening.
Like what are we talking? Like
Now,
35 out of 40?
30-ish. You know,
Okay.
some of that I would say was hesitance and not true limitation. Like I stretch them? Could they stretch themselves? Yeah, there's probably some guarding due to pain and some just overall hesitancy on their part. But some of them, for deeply impacted teeth, I would say they're even less than 30, even at a week. I mean, I think there's some of that going on, no doubt about it.
Yeah.
And so I think you're not stripping temporalis, you're not stripping medial pterygoid in those patients. And I think some of them have,
Just having surgery in the back of your mouth, right?
yeah, swelling, inflammation, maybe some subperiosteal hematoma,
Yeah.
expansion, inflammation. I don't
Yeah.
know. But I mean,
I
I
just,
would say
on
those patients had it.
another group of patients that you see, like mandible fracture patients, like angles or bodies or
Mhm.
parasymphysis, maybe not. Let's take parasympathesis out. Bodies and angles. I mean, their mouth opening is limited for a little bit, but I still think they're better at 6 weeks than the sagittal osteotomy patient. But maybe, maybe I'm wrong.
I can't speak to that, and because I would say I never looked at that, and then in residency where most of us do the majority of our trauma, and with I would say the general trauma population, follow up is limited sometimes. Those are the patients
Yeah,
that
yeah. It's
often
a different
you
group.
never see
Yeah,
again.
I agree. Yeah.
And
All
you
right, man.
also, but yeah, you're right. You're not going medial.
Yeah, I don't know. Anyway, I think it's kind of
So
an interesting noodling topic, whether or not we're having that many solutions to throw out there. Um, but I think generally rehabbing, people follow consistent pathways. Pretty unusual for it to be internal derangement. Most people respond to conservative
agreed.
measures. Maybe some tricks in the future to rehab people quicker. But Dr. Watson is going to be coming up with those, which I appreciate your help.
All right. Well, that's it for talking jaws.
That's it.
See you next time.
Are we next week?